special. Hey, and welcome everyone to PerfWeb. I don't even know what number
93.
this is. 93. Yeah, 93. Can you believe it? We've done 93. And we've got a really neat program today and a super cool panel with us. Let's just dive right in, however, to the opening remarks if we can. If you have a question, you want to reach out to us, you have a topic you'd like discussed, you want to be a part of our distinguished faculty and give a lecture, be a visiting lecturer, like we did with Emily Foreman a couple of weeks ago, which was fantastic. I had an author of a publication on RAP, and she actually came in, remotely, of course, which we have all that technology. So if anybody out there in web world would like to do that, please reach out to us, contact@perfusioneducation.com. Now, here's our call-in number, 832-239-5358. If you call that number, you can be live on the air with us today. We frequently say nobody ever calls that number, and then we had somebody calling and nobody knew how to answer the phone. It was pretty funny. Okay, if you look down here, you see our scroll bar. We keep our number open. It's always there, right there. And our scroll bar with everything, our LinkedIn, our X. I don't have to say Twitter anymore. Our X, our Facebook, FaceTime, whatever it is. And so we have all of that information right there. YouTube. Please make sure you like, subscribe, thumbs up, share, do all of that stuff. Okay, next. And here's our podcast. You can listen to us if you'd like while you're driving and learn something, hopefully, maybe even be a little entertained. But whatever your favorite podcast streaming platform is, you can find us just by looking up PerfWeb in the search bar, and you will find us. Okay, now I want to talk to you quickly about our app. You can use the QR code if you have you want to go to the App Store or to Google Play. And this is a really cool app. I'm going to show you some things that it can do. In this particular, so sometimes I go over the perfusion part of it, but they have the perfusion quick calcs. You can put this in and it spits out all of this information for your case. But I want to focus on something else today, so we're not spending too much time on this. We can get on with our lecture. But we added a new feature, Oxygen Delivery Index, so DO2I. You'd put in the patient's hemoglobin, 10. You'll put in their SaO2. We're going to say this is 85. You're going to put a PaO2 in of, what do you think that would be, 52? And we're going to do a cardiac output. Your ECMO flow, we'll just say, is 4 liters. Or the patient's cardiac output's 4 liters. BSA of the patient is 2.02. And we can click calculate, and it gives you a DO2I of 232.1. Now, without changing anything, let's just say this was actually a perfusion case, and as opposed to this, because your saturation, of course, wouldn't be 85% unless you had a problem. Yeah. You can click reset if you want. It'll just reset everything. And by the way, if you click the I, you get all of the information, including the formula. But what's cool about this app is it does all the previous calculations for you, because usually you have to know the arterial oxygen content, and then you can calculate the rest of your DO2 and then your DO2 index. It does it for you. So you're on pump and you have a hemoglobin of 7. You have an SaO2 of 100%. Your PO2 is 350. Your pump flow is 4.5 liters. And your BSA of this patient, we'll say, is 2.2. Calculate. You can see your DO2I is 216. That's low. You don't want it to be that. How can we best correct it? Without hitting the reset button, I can come up here and I can change this to a hemoglobin of 9. I can recalculate it, and it puts us over to magic 270 number. You could have tried to do that with the cardiac output. You could try to do it with the PO2. There's all different things you can do. But at the end of the day, we know we want a cardiac DO2I of above 270. So cool little app, cool little feature. Check it out. I need to sell 1 million of them. I've got like 999. Yes, to retire. Exactly. Okay, we'll go on to the next thing. I want to introduce everyone here. Everyone already knows my co-host, Vicki Carlisle. Vicki is a BSN, RN BSN. She's a CCRN. She's also an ELSO certified adult ECMO specialist. She's been in critical care medicine for over 10 years. She received her bachelor's in nursing from the University of Texas Health Science Center in Houston, and she went to nursing school at CISIC. Most of her critical care experience has been focused on in the CV really unit, where she developed a real interest in ECMO support and perfusion. She has goals, aspirations of going to perfusion school, but right now she is our director of nurse ECMO specialist and also education. She is our education director. So she wears many hats, and she's got some very serious roles, but she is very, very well known and respected as an incredible educator, and we're putting together some really neat courses for nurses and perfusionists moving forward. We already mentioned she's certified in critical care and ECMO certified, and again, working on your degree in perfusion. Now, new to our faculty is Thomas DeSalvio. Thomas has worked in the field of cardiac surgery and heart patients since 1988 in a variety of roles. He's a graduate of Texas A&M, and I've known Thomas for well over 10 years, class of 1990. He has a degree, bachelor's in exercise technology with a specialty in corporate fitness and cardiac rehab. He was a member of the Corps of Cadets, Squadron 10, class of 1990. In 95, Thomas obtained his post-baccalaureate certificate in cardiopulmonary perfusion from THI. He's one of the very few perfusionists to have had the privilege of working with two pioneers in the field of cardiac surgery, Dr. DeBakey and Denton Cooley, both of whom I also knew. Loved Dr. Cooley, and I'll just leave it there. Thomas credits his mom, Irma DeSalvio, for setting an example of hard work, integrity, and service, that are virtues of success. He pays his respects to the late Dr. Robert Guide, who gave him his first official job working in private cath lab. Because you were a cath lab technician for some period of time. And it's really interesting because I'm going to be giving my commencement address to the Baylor Scott and White multidisciplinary cardiovascular training center, which is perfusionists, echo cardiographers, and cardiac cath lab technology. So that's what you actually did. Thomas has over 27 years in long-term and short-term artificial life support devices, ECMO, VADs, and so forth. And you're basically a tremendous participator in a lot. And you like to mountain bike. You're an adventure racer, triathlete. I'm a triathlete too. I can get up out of the bed in the morning, go and race myself to the kitchen to make some coffee, which is usually really a crawl, and then I can sit down and stand back up. That's triathlon for me. Yeah. He's currently working towards your black belt in karate. So now everybody knows who you are. Thomas, welcome to the fold. We're looking forward to having you as part of this program and having your information shared. Yeah. So we're going to go ahead and just jump right in now and get started. We're going to go to my slides. They're up. All right, so let's get started. So I got to give credit to my co-host, Vicki Carlisle, because she actually put this slide program together, Intra-Aortic Balloon Pump, but I modified it or adapted it for the perfusionist. Because, I go to work a lot of times, and I know a lot of perfusionists, and some perfusionists really do understand the balloon pump, and some perfusionists, however, do not understand it at all. And it was a core part of our education when I went to perfusion school, but it is no longer that. And so there's a part of training, I think, that's really missing things that need to be there. It's just basically turned into a nursing service thing, but yet in the operating room, we're so dependent on being able to do it in many places. Maybe not at that particular academic center, but in the real world community hospital, we are really dependent on to use it. How do we use it, and what's right, and how do you do it? So let's take a look. No disclosures. So here's just a quick look at coronary circulation. Of course, our coronary circulation, the point of this originates in the aorta. I'm going to just jump right into this slide. And what is a balloon pump for? Well, increased diastolic pressure and diastolic time, DPDT, which increases coronary blood flow, thus O2 supply. So our goal is to increase the oxygen supply to the heart. But it also has a secondary function, and that is to decrease afterload. Decreases workload of the heart, thus O2 demand, and promotes improved LV emptying, thus improved coronary microcirculatory perfusion. So at the end of the day, the balloon pump is designed to increase oxygen supply to the heart, decrease oxygen utilization of the heart, or demand, if you will, and it is timed during the cardiac cycle to make that happen. Now, the part on the right over here, this graph, what I wanted to show this for is because we all know that if you are measuring cerebral oximetry on bypass and the neck gets turned a certain way or the heart gets picked up a certain way and you occlude the drainage out of one of the jugulars, you will see your cerebral oximetry numbers go down. And that's because you have a decrease in perfusion due to outflow obstruction. Well, the same thing happens in the coronaries. And so here's the drainage back into the right atrium via the coronary sinus. If your heart is distended and your right atrium is full and your left atrium is stuffed as well, it all tends to back up through the coronaries, ending up having an inflow or a outflow, depending on how you're looking at it. You're obstructing the inflow into the right atrium, causing a perfusion deficit upstream. So it's an obstructive type of phenomenon. Balloon pump helps you to reduce the heart size, especially better RV and LV emptying, because if your LV is backed up, your right side's going to be backed up too. It all flows backwards, and that creates a vicious cycle. So, and then the cardiac cycle, I think I blow that up. I do. So we're going to start off with, there are technically 8 phases to the cardiac cycle. However, we're only going to focus on 5 in this slide and 6 a little bit later on. But here you see where it says start. We're going to start with isovolumetric relaxation. And what this basically means is the atria are filling, the right ventricle and left ventricles are relaxed, but the atrioventricular valves, vis-a-vis tricuspid and mitral valves, have not yet opened to fill the ventricles. So that's what this phase is and where we start. The next phase is a passive filling phase. The right atrial and left atrial pressures exceed that of the ventricles, and the valves open, and the blood starts to pour into the ventricles. At some point after that's over, the atria contract to further empty and fill the ventricles, and this, of course, is atrial contraction. Then you have a phase, and this is a critical phase. You have isovolumetric contraction, and what that means is the heart is beginning to squeeze. It slams shut the tricuspid and mitral valves, but the aortic valve and the pulmonic valve have not yet opened. So it's isovolumetric contraction. It's a very important phase of this discussion. And then you have what would ordinarily be termed the rapid ejection phase, but we're only going to stick with the 5 that are on this slide. It's the ventricular ejection phase. So the aortic and pulmonary valves open and the ventricles are ejecting their contents out into those particular sites, one to the lungs and one to the systemic circulation. So during this phase, isovolumetric contraction, is when you want your balloon to deflate. And during this phase, isovolumetric relaxation, which is after the aortic valve, right after the aortic valve has closed, is when you want your balloon pump to inflate. So that all of this time is used for coronary perfusion. Okay? Make sense to everybody? Am I explaining this well? All right. Here is a great illustration. And you can start from right to left or left to right. I'm going to go left to right, if you don't mind. The balloon pump inflates rapidly. Uses helium. Why does it use helium? Helium is the second lightest gas. You can use hydrogen, but hydrogen and oxygen mixing together tends to not be a good thing to do. So we use helium. Used to use CO2 because we thought if it ruptured, it would be less problematic at the gas going into the blood back in the early days. But we use helium because it's a very light gas, moves very rapidly. When the balloon inflates in the aorta, blood that ordinarily filled this area that's now filled with a gas-filled balloon goes and it gets displaced, both superiorly, going towards the head and going towards the heart, but also inferiorly. Now, in theory, the balloon inflates inferiorly going up this way, but it happens so fast, really probably isn't as useful as one would think it would be. But so some of the inflation, the displacement of this blood causes the pressure to spike. But again, it's going to go to the head and it's going to go down the coronaries and it's also going to go towards the abdominal vessels and the legs. So you have to recognize that. Now, when you do that, we're going to look at different diagrams. That's where you're going to increase your diastolic pressure vis-a-vis your coronary perfusion pressure. Now, in this particular slide, I'm doing this in reverse. So this would go from deflated to inflated, but I'm going inflated to deflated if you don't mind. Here the balloon is deflating, and when it's fully deflated very rapidly, now you have an area that at one time was filled with a gas-filled balloon, and blood from this part, these parts, and even down here are going to rush to become equilibrated. So you have a space that has no blood in it because it's a gas-filled balloon, deflates, blood rushes because we have to be in equilibrium, right? And it rushes from above the heart, just above the valve. It rushes from the head. It rushes from the legs. And all goes to fill that spot. That is when you want the balloon pump to actually be the heart timed so that you're in isovolumetric contraction. And because that's the second phase of the balloon pump, reducing the O2 demand by reducing afterload. And the best way to explain this is by the Three Stooges. 2, 3. When the balloon deflates, it's like the ventricle is trying to open a door that someone on the other side is opening at the same time. That's balloon deflation during isovolumetric contraction. That's how you reduce the O2 utilization of the heart. Make sense? Mm-hmm. Okay. Now, here is a normal arterial waveform. This is the rapid ejection phase. The ventricle is ejecting. This is the reduced ejection phase. The ventricle is still squeezed, but not much else is coming out. Then it goes into isovolumetric relaxation, and you have here you see the Aortic valve is closing. That's what the dicrotic notch signifies. So your pressure is dropping. The semilunar valves are filling on the leaflets. They close, and you see a deflection. That's the dicrotic notch. That's aortic valve closure. And then here you have all of this time of diastole. You get to end diastole, and the cycle starts all over again. From here to here is really where you're getting your coronary perfusion. More of it is here with the valve closed for obvious reasons, but it all starts here. There is some little bit here, and we're going to go over that as we move forward. But that's a normal arterial waveform. I put this in here because when you can compare it simultaneously to the ventricular waveform, it all makes more sense. So that everybody knows this, right here is your LV EDP. Your left ventricular end diastolic pressure is not here or here or here. It is here. It is just before the ventricle contracts. And because, of course, it empties, relaxes, and it fills, and you have to account for all of that. So an LVEDP of between 0 to 5 is normal. Can be much higher than that in different disease states, but we'll talk about that. Here you see the ventricle is ejecting, but if you notice, you don't have an arterial waveform yet. So right here at this point, here, that is where the aortic valve has opened. Now, as we come up, you now have an arterial blood pressure, comes down, and you see the aortic valve here is closed, your dicrotic notch, and the interventricular pressure continues to fall. The heart fills. You have an LVEDP, and you have the ventricle ejecting again, or contracting, but not ejecting. Ejecting, valve is opened, comes back up, valve closed, and the cycle continues to go on and on. Now, in a disease state like aortic insufficiency, what you'll see is a much lesser of a, and let me just come here and show you this, and you have from about 5 LVEDP to about right here 75 on your aortic diastolic. That's about 70 millimeters of mercury. That's the difference, and that is a normal number. You look at this aortic insufficiency disease state, you immediately notice that the patient's diastolic pressure is much closer to the LVEDP in this patient, and the LVEDP is much higher because that ventricle is emptying, but then it's refilling not only from the atria, but also from the aortic regurgitation. You also notice a very subtle deflection point, so it's not completely incompetent, obviously, but it is incompetent. You don't have a pronounced dicrotic notch, and but you don't have any aortic stenosis because these numbers, the systolic numbers, are the same. You go here and you look at this waveform. Now this happens to be a post-TAVR placement that still had residual stenosis. They had to go back in and balloon it. And what's obvious here is this is the ventricular systolic and this is the aortic systolic. There should not be a gradient. A gradient of less than 5 is acceptable, 5 or less. Anything more than that is unacceptable, but you will become symptomatic with a gradient of as little as 20. And so you are a candidate for TAVR in that particular circumstance because you will remodel, and it's not good for the heart to be like that, and you can be symptomatic. The problem with aortic I don't want to get into that, but let me just move on from there. However, that's the point of this slide. You still see the waveforms overlaying each other. Here is remember, this is your LVEDP. The pressure just before the ventricle starts to contract Interventricular pressure is rising, but it has not yet reached the pressure in the aorta at its end diastolic pressure to open the valve and eject its contents. Here is a very nice graph, and I think that Vicki Carlisle is going to go over this a little bit as we move forward. But you see here the coronary blood flow on this axis here, and you see over here whether you're in systole or diastole. This is one complete cardiac cycle. So you see some coronary filling during systole, but you think to yourself, the ventricle squeezing, the coronaries aren't going to be but some flow is going to get ejected down them, but it's not as much. But look here what happens in diastole. Here the ventricle is relaxed, but the valve's not closed. The valve closes, and you have all of this time. This is your diastolic time. This is your diastolic pressure. This is your diastolic time. So dp dt. All right, and now I'm going to turn this over to Vicki Carlisle and have her do the next phase of this lecture. And here's your...
I need the pen.
Here's this. Yes, the pen's in my hand. I'll give you that. There you go. I'll move this out of my way. There you go.
There we go.
Here's the pen. And you can just go to your next slide.
Okay. Okay, so I'm going to just do a quick, brief overview of the history of balloon pump, kind of how we got where we're at now. Adrian Kantrowitz and Arthur Kantrowitz were the ones that came up with this back in the 1950s. They wanted to, using what Joe just talked about, how most of the perfusion happens during the diastolic phase, they wanted to have a systolic blood pressure during diastole. In an attempt to increase coronary perfusion. Started out in 1953 with some dog experiments. They wanted to kind of delay some of the blood flow back towards the aorta by putting a cannula in the femoral artery so that systole would go down, it would hit that cannula and come back up into the aorta, hitting right at the diastolic phase, which is what this graph over here is showing. So this, of course, is the normal aorta here. This is the wave coming back up from the femoral artery, hitting right in diastole. The bottom one is showing coronary perfusion, with this large hump here showing the increase in coronary perfusion because of that delayed arterial pressure coming back up the cannula from the femoral artery. 1956, they also tried using a pacer wire connected to the phrenic nerve and part of the diaphragm wrapped around the aorta, causing it to contract on the aorta, giving some backward pressure during diastole. 1960s was their biggest project, the auxiliary ventricle, which I'm going to show in the next slide. It was the first mechanical device that was inserted in a human. Other concepts during this time, the external leg compression, kind of like a large SCD that would go up all the way up the leg and into part of the abdominal area. It would just compress outside of the body. They also had external aortic compression, which was applying pressure around the abdominal area. Another one that some other physicians were working on during this time was removing blood out of the body and re-injecting it in diastole. None of those were very successful. Okay. Adrian Kantrowitz was actually a public health service research fellow, and his brother Arthur Kantrowitz was a professor of physics. He did aeronautical engineering, and he had a lot of knowledge with fluid dynamics. Okay, here's a picture of them here. They're actually holding their auxiliary ventricle here. This one is a diagram of it. These little connectors here are Dacron grafts. They would actually cut the aorta arch there and install this auxiliary ventricle right onto the aorta with those Dacron grafts. It is basically a large bladder with an external film around it. You can kind of see it better down here. So this is the bladder part, kind of like a reservoir, and this is an external film around it. It was that film that would inject with air, compressing the bladder and causing like augmentation. A lot of problems with this, being clots for one. It was very prone to clotting, and it was a very extensive surgery for them to put this in place. This is the console. They intended this to be a destination therapy, so patients could get this and go home with it. Being non-obligatory, it could actually be turned off and turned on as the patient needed it to be. This would be like a EKG, monitoring the rhythm for timing. This is the chest wall here. And this is, of course, the air going in and out to compress that bladder. Okay. You like that?
Yeah.
Okay, so again, the auxiliary ventricle had many issues, clotting. It was a very invasive procedure to get it placed. They did actually use it in 1966 in a 63-year-old woman. She was a terminal heart failure patient. She did really well. Her mentation improved, her urine output, everything was on the recovery. On day 12, however, she suffered a massive stroke from blood clots from the auxiliary ventricle.
Yeah.
She was the first patient implanted with a cardiac assist device, and she was intended to be discharged home with it. 1962, they had a polyurethane balloon filled with helium. Like Joe said, they did use CO2 for a while as well, just because it's more absorbable into the blood. The helium, however, can transport back and forth much faster, so they did go with helium. They tested it in dogs initially via femoral insertion, and then in 1967, the first successful use in a human via the catheter balloon pump. Had 7 hours on balloon pump therapy. It was a 45-year-old female with an acute MI. She had almost immediate improvement in hemodynamics. 1968, introduced into clinical practice. Clinical studies at the time really was kind of varied on improved outcomes, but it was still widely accepted because of that immediate improvement in hemodynamics once it was inserted. So physicians welcomed it, and it was actually still is the most commonly used mechanical assist device. Okay. Of course, the Kantrowitz had a version of this catheter balloon that he also wanted it to be a permanent take-home destination therapy. Since the auxiliary ventricle did not work out, they did try an implanted version of the balloon pump that was inserted through a port in the chest into the aorta, and they could go home with it versus a femoral insertion here. This gentleman here is Haskell Shanks. He's 64 years old, and he was at Sinai Hospital in Detroit. This is 1971. He is the first person to be discharged home with a left ventricular assist device, which was this one here inserted through his chest. He went home with several different consoles. He had a vest version. He had a wheelchair unit, a lot of equipment that went home with him, and he did really well for about 3 months. But this insertion site here ended up getting infected, and he did end up passing from sepsis.
Huh.
Yeah, the second patient that went with this device also had the same complication, sepsis at that insertion site, so it was abandoned until they could figure out a better way for that catheter. to go in and not
Drive
catch
line management.
the drive line management.
Drive line management is a huge problem. Still is today. Still is today.
Yeah, well, imagine being at home and you
Just
have to take a
getting-
shower, or you want to.
People
don't
do
take,
now.
You don't take a shower.
Right? Yeah,
and
they do. Yeah, but
you
in
gotta
this
clean your-
particular,
clean
in the
your
old
drive line.
days, yeah, they've at least improved, I think, on that. And of course, how they insert the drive lines, going,
Right.
quite a bit under the skin to
Or
try
even
because you
tunneling,
have
yeah.
that, the tunneling of the way they do it, because of that tissue ingrowth is
But
just
don't
such
they
a
also have special
enormous
stuff on the
problem.
outside of the drive line now that helps it clot and heal? There's a
Yeah, that's interesting stuff.
yeah.
Sorry,
Pretty
don't mean to
fancy.
Oh,
interrupt.
that's
Sorry,
okay.
yeah.
He did continue trying to refine that, and unfortunately, he passed in 2008. But they had actually given him approval to start another trial with this, using the techniques you were talking about. But mostly femoral placement came around about 1979, and that's the way that it is inserted most of the time now. Adrian Kantrowitz, just as an interesting fact, when he was 90, he went into heart failure, and he actually had a balloon pump for some time, and it ended up passing the year after. Okay, so 1986, this Dr. Kantrowitz still here. He was working towards a fully automated kind of closed loop system that could do automatic retiming, changes in the cardiac cycle, and all of that could be automatic adjustments with inflation and deflation, and wouldn't require as much adjustments from, I guess, humans. It could do it all on its own. So he teamed up with Asensuki, which is a car manufacturer in Japan, and they come up with the CoreArt BP1. It was the first closed-loop automated system. This is them holding a very large printout of the strips. They would record long periods of time and kind of gauge the accuracy of timing, and it was found to be 99% accurate, where inflation would begin within 20 milliseconds of the dichrotic notch. Both Datascope and Arrow would follow shortly after. This right down here is the initial one, the CoreArt BP1, hit the market in 1991. Datascope here with their initial CS100, and Arrow had their AutoCat 1. Datascope was acquired by Ginegy in 2008, and McKay was acquired in 2000. I believe I've never used actually any of the AutoCADs. Have you?
The Arrow balloon.
Yeah.
I have used the
Yeah.
Arrow. I've used Datascope. I've used, of course, the McKay, Getting, whatever you want to call
Yeah,
the company.
Getting, yeah.
I believe
I've
there is
used
the
I've
AutoCAD
used
3 now, but
I don't know. I used the
Okay.
original Arrow. It wasn't an AutoCAD.
That was one thing I was going to ask real fast was the difference in pronunciation.
I've used a SMEC balloon. I've used a Contron balloon, which is the, the Contron is Kantrowitz, and that was a big giant green machine, and it had these old style depressible buttons, and you had to do it. It was 1, 2, 3, 4, 5 on the numbers, but you had to push 1 and then 6 and then 3, 2, 4. It made no sense whatsoever. And one of them was a fill. You'd have to hold it, but it was a big giant machine. It was incredibly large. And then the SMEC balloon was kind of a crazy little idea too. But all of those, really, I think Datascope was the dominant. Arrow is a great company with a great balloon pump, but it just has never had the traction. But it's a really good system. But McKay, or Datascope McKay now, dominates the balloon pump market, I believe.
Yeah.
yeah, I haven't really used any of the AutoCADs. Mostly I use the CS 300, although I think their newest one is the Cardio Save. But yeah, McKay Datascope. I believe that's all I have on that one. Used more than 3 million times now, the balloon pump.
It's a lot.
It's a lot. It's still the most commonly used mechanical assist device. Okay. I'm going to turn it over to Mr. Thomas.
Very nice. Excellent.
Thank you.
Let's see if I can stretch this over.
Yeah, it should just go right
Slide
over the
over
thing.
that way. Is that a
And you
good
know how
angle
to
for
use
you?
that slide finger to change slides.
Okay.
Yeah.
Awesome.
You need any help, let me know.
Okay. Hi, everybody. My name's Thomas. I want to start off just saying that I'm really honored to be here with Joe, to be allowed to be here. And
Oh, thank you.
it is a big honor to be in your presence. And Vicki, I am so impressed with you. We worked together yesterday on a massive transport, and I was really impressed with your taking charge of the situation. I thought you did a great job. I just kind of sat back and watched and learned. And that's, what we all do here. We take some from each other. And
That's right.
But I'm very honored to be here. It's my pleasure and my honor to be here.
Thank you very much.
Yeah. If you haven't already, please like and subscribe. It does help with the algorithms and gets the word out. So take this moment in time. Remember, there's a little like button. Push the little button. If there's a subscribe button, subscribe, and take the notices that whenever we go on. So the indications for intra-aortic balloon pumping. When
This will help to answer the question of
Oh,
our
yeah.
person. Yeah,
We-
hope
we
you're
had-
listening.
we had a question.
Abu, I hope you're listening.
You can call in and ask a question, and you can also ask questions on the chats. We did have that first question. When you read these indications, what you can look at, you can take a screenshot of this, and I don't have to read them all, but just look at this and say every one of these is a result of heart failure. There are two that are not, and that would be a PCI-assisted procedure or angina, if a patient's having angina. But pretty much these are all just related to a heart failure situation. And you can read all about the effects that take you to heart failure. So here's a good look at some indications for reasons for doing the balloon pump. And I think a lot of people, the reason that it has been so widely used is primarily that this is your first tier of intervention. We try drugs, inotropes, and this is the next one. So once we've exhausted inotrope therapy, we're going to go to the balloon pump. And it's considered one of the easiest to put in because it's not going to require major surgeries. You can put it in pretty easily. And you can see the procedures that are, it is primarily used in. Contraindications for the balloon pump. Probably the most important of these is going to be aortic stenosis, aortic regurgitation especially, aortic dissection, or aortic stenosis, particularly in the peripheral vascular arteries where the legs are, because this does need to go up the legs. And when it goes up the legs, if you have a lot of stenosis, a lot of tightness there, the catheter can actually occlude the blood flow down the leg. And so I think there's the next slide where we'll be talking about some things that you want to do for maintaining the blood pressure, for maintaining the balloon pump. And one of the things is going to be to check your peripheral pulses so that you know that you're actually getting blood beyond where the catheter is fitted into the femoral artery. It is typically inserted in the cath lab. And I wanted to mention it's inserted in the OR often during heart surgeries. As a patient comes in the room, the number one, I made this up, so don't tell me if I'm right, Joe. The number one indicator for successful weaning from cardiopulmonary bypass is ejection fraction. A low ejection fraction tells you right away you need to start thinking, where's my balloon pump, where's my Impella, where's my ECMO, and do I have these things ready to go? And so you might put it in at the start of the surgery so that we can start relieving the pressure on the heart ahead of time and take them into the surgery where we can actually arrest the heart and give them a good arrest with cold cardioplegia, cold and a lot of it. And make sure that it's actually getting through using, watch your pressures and watch your flows to actually make sure it's going there to give the heart a good arrest. It is occasionally inserted when you're coming off pump. Before you come off pump, you can insert it. And then also after coming off pump, when inotropic support just isn't enough to keep you going. And you'll have that first indication at the very beginning of the case when they do the TEE or they do an echo and they in the surgery at that time, not before, but at that time where you can see what the ejection fraction is and you know that you're probably going to be putting a balloon pump in. This is a great picture of just that's disposables and how they look. You can see, and there's an insertion kit. Let's see if this works. Yeah, this is your insertion kit up here. And then you have the actual catheter itself. And training of the nurses is pretty important, especially as the perfusionist. You are going to be more involved in explaining to nurses what they need to do and how they need to do it. And you hand them both of these trays, and they will hand you back key components of it. And if we're not really not talking about that, but this is the disposables. Placement of the balloon catheters. Typically, they go in the femoral artery. We do also do a lot of off-label axillary approaches now, and that is done in long-term heart failure patients that we are hoping to bridge them to either home therapy using an LVAD. One of the LVADs probably a HeartMate, or bridge them to a transplant. And we're just trying to keep the heart going long enough and keep the patient getting enough oxygen to both the coronaries and the brain long enough to get them one of those two devices. It's very important to know where your radiopaque markers are on the balloon, because the positioning of the balloon is really important. And up at the top, there's a marker up here at the top of the balloon, and there's a marker at the bottom of the balloon. And x-rays are extremely important. You want to have x-ray verification or validation that the balloon is in the right place. And these are very good things to look at. You want it to be 1 centimeter below the aortic knob. And in the aorta, I guess if we looked at it like this, it's about right here. So you want it below where your coronary perfusion is going to take place at. But you want it high enough that it's right at the notch. The balloon will extend down.
I don't think they can see your drawing.
Oh, you can't see it?
I was going to say, I
No.
think it
Okay.
cut off.
Well,
Because I think your
The major point
that
is-
screen
yeah.
doesn't go all the way over.
you want to be below the great vessels, just a little bit, and you want to be above the renal arteries. That's where the markers need to be. And you can see that, you can kind of say the second or third intercostal space, you can feel that. You can see under x-ray where these things are. But that's the key thing, is below the great vessels and above the renal artery. This is a great picture. You can see where it's at. Down here would be your renal arteries. Did that come up? Yep, they'd be coming off here. That's my kidney. Do you like my kidney?
Kidney beans.
That's
Yeah.
pretty good. So
There-
you see the left subclavian there. So you really have a good. You want to go back to that? I would really focus on that a little bit, because I think for us, we know it already.
Right.
But I would definitely go over that anatomy. This may be rudimentary for some, but for some it's not. So I would focus on those people and maybe even talk about that anatomy a little bit.
Right. So the left subclavian artery continues around. I don't know if you can see this. Yeah, it continues around and goes down the arm. And this would be your left carotid. And this would be your lima with flow to the, I try to do it backwards, right carotid. And the balloon pump needs to be below what we call the great vessels. I call these the great vessels. It just makes it easier. And you'll see it right there. And I don't really know how to know where the coronal arch is. What was
The
that word?
carina?
The carina.
The carina is where the right and left bronchus come off on your X-ray.
Okay.
So, but when you have put the X-ray up, we can go over that.
Okay.
Yeah, I think
But
we got
basically,
pictures
what
coming
you're
up.
looking at is that zone where you see the arch coming around. So from the ascending, and then you have the transverse, and then coming around to the descending thoracic. On X-ray, that area is the knob of your aorta. So right there, that's because it's coming up and over, and it causes it to look like it's a knob.
Yeah.
But you'll see that because I have an X-ray on there.
Okay. And also, you don't want to have too much of a bend in your balloon. So that's part of, in real life, it kind of is more straighter because the catheter doesn't bend. It's a good time to talk about other things other than just physiology. There's charging ability with this. And For the hospitals, they can charge for setups and they can charge for removals, and that's it. What's important about these parts down here, which I want to zoom in on, this accounts for time. Yeah. This accounts for your time as a perfusionist or as the person who's taking care of the balloon pump, because you can't really bill for standbys. You can't really bill for receiving a patient or monitoring or troubleshooting or transporting, exchanges, revisions, and ambulations, and you can't bill for those things. You can bill for the insertion and you bill for the discontinue, and that's it. But it's a person's time is being used, and we want to have enough people, enough employees, and so we need something to validate our time and say that yes, we do need more people to do this, because there are so many balloon pumps being used, and one person taking care of 10 balloon pumps can be unsustainable. And so you want to account for your time and show that we do need more perfusionists or more technicians to take care of these balloons. And it's part of the record that goes into Epic, and it's part of just your presentations when you go to the management and say we need more people. When we talk about charting, you can have your chart drawn up a lot of different ways. This is how we at a prior facility set up our ECMO our balloon pump charting. And I'm trying to zoom in a that bit for you. And you can take a picture of this and just see the modes and what we're charting. Charting the mode that it's on, if it's an auto, semi-auto, or manual. The augmentation, 1 to 1, 1 to 2, 1 to 3. And we use the word frequency. Triggers, if your EKG, pressure, internal, pacer. I guess we wrote internal twice, that's interesting. When it's filling on auto, semi-auto, or manual, which the IABP mode and the fill mode are kind of the same thing nowadays, so I don't know why we kept that there. It's an old
Excuse me.
pastime. You want to make sure you have your alarms on and that they're audible. And then the catheter tubing. You always want to check your catheter tubing, make sure there's no blood. And you want to document that there's no blood in your catheter tubing. And one thing I was going to give you a quick freebie on, if you take a picture of this, hospitals generally are reimbursed a reimbursement. However, these 3 items are actually billable by the hospital. And if you, in your presentation, want to look smart and tell them, hey, you can actually bill for these things as disposables and not take the hit on them on the general procedure charge, I'm giving you for free the billing codes. If you want a picture of that, you can, right here.
With the caveat, if you don't mind me adding this, is we are not we do not recommend how to charge for things. So if anybody does anything, please, you have to check it for yourself because I don't want CMS coming and asking me about this. So this is a suggestion only, right? Yeah. Good. Fair enough.
These are all ideas. Everything I do is a living document that can be changed at any point in time. I created this troubleshooting for IABP list because we were doing a lot of off-label procedures, and when you're putting a balloon pump in an axillary, it's going
and just
backwards.
so people recognize, you're coming from an academic institution.
Right.
For those of you not in academics, they may not see this, but you never really know, right?
Right.
So just for reference for our audience, you lived in a place and worked in a place for many years that did what we in the community would consider crazy. Okay, so just keep that in mind, okay? And so your point of reference, your comfort with this is way different than other people's. I just want to make sure everybody knew that. Go ahead, I'm sorry. Forgive
What
me.
I do, this is a pretty thorough list, and so if it doesn't
Somebody
apply...
loved my comment, by the way.
yeah.
Go ahead.
Everybody loves you, Joe. You're the best.
Just ask me.
Yeah.
Just-
So as you encounter a call to check on a balloon pump, the typical conditions are gas loss, gas gain, and gas leak, and they're all essentially the same thing. What we do with those, it depends on where the catheter is located. Ephemerally, you're going to get to skip things, but if it's in the axillary, you keep things going. And so if it's not applicable to where the placement of the catheter is, you just skip it. But the very first thing is always no blood in the catheter. You always want to make sure that the gas line does not have blood in it. You want to make sure you've got good radial pulses if it's in the axillary. You want to make sure you've got good pedal pulses if it's in the femorals. These are just things that you do to try to troubleshoot the catheter itself. And you can read them and you can take a picture of this, take a screenshot. I encourage you to do that. And I actually will document this, everything that I did in Epic or on a piece of paper saying this, I went through this process to get to the big ones. And this is the ultimate right here. You do as much as you can to avoid changing out a consult or recommending a catheter change out. And once you've done all of these things, you are at the point where you need to change your console and recommend a catheter exchange. And one interesting thing is always check this right here. People forget about this. They assume that the helium tank is open because it says full on your meter. But in reality, the helium tank can be slightly not open all the way, and that can be your problem. And that took me a while to learn. We had an experience with a balloon pump that was constantly failing, and nobody could figure it out. And one day, I decided to change the helium tank, and it wasn't open all the way, and that was the problem. It just happenstance. Maybe it's luck that I figured it out, but that's where I learned that one.
Yeah, the balloon pump can hold enough helium without a tank on there at all for 32
Yes.
autofill cycles.
Yeah.
So you may not know for a while.
That's true, because it can be on empty, and it'll still last like, what, 2 weeks?
Like
3 weeks?
32 autofill cycles.
It's a lot. 32 days, right? It's a lot.
I don't know if it's 30, however many
No, I
times it
think it
autofills
autofills
every
more
2
than
hours,
yeah,
right?
it autofills more frequently than once a day. I think you're right. I think it's every 2 hours.
Yeah, and I think it's faster. The autofill, but does this internal check every couple of seconds, something like that. They're very, very technologically intensive machines. It's always good to have checklists, at least in your mind, if not something that you actually mark on Epic or in your charting. And this is, of course, a living list, so you can adapt it to your facility. It's just things to keep in mind. You want to make sure the machine is plugged in whenever you're done transporting. You want to make sure the battery's adequate, the EKG and the blood pressure are working.
I need to interrupt you 1 second. Somebody is asking if you could describe the gauze under catheter exchange. So can you go back
Sure.
and do that? Because that's not something I could have waited till the end. I'm sorry.
That is actually an excellent question. So frequently what happens is, even in the femoral artery this happens, in the haste of putting these things in, because it's usually in a pretty critical time, sometimes the surgeon or the cardiologist will have their needle too steep. So the skin is flat like this, and the needle is kind of going in straight, and then the catheter goes like this inside of the patient. But in the meantime, what happens is, and it can happen in the axillary or it can happen in the femoral artery, what happens is over time, people want to lay it down like this. And so the catheter goes like this, and then like this. And because of that, it will cause gas leaks, gas alarms. And so you want to try to have this smoother curve. So if it's sticking up like this, you build a gauze mountain around it to hold the catheter from being compressed down, and it gives it a smoother entry into the skin.
You don't
into
have
the
an
patient.
obstruction because the gas has to move quickly.
And it's going through a small
Small little hole.
Yes. Small lumen. And that's what that was. So that was a great question. I probably should have pointed that one out to you. I'll put that on my list to make sure that, because
That's okay.
yeah.
Somebody asked a question. I'm
That's
glad.
a great question. One thing that's often forgot is when you're checking your balloon pump over, is to make sure the alarms are on. Did I write that on there? Augmentation alarm set. You want to make sure you have the alarms turned on, and one of the key ones is the augmentation alarm, because that's usually your first indication that the blood pressure is dropping. And the pump will go off, and then everybody comes in and they're annoyed by it, but then they realize, oh, it really is rare. This is a situation we need to be aware of, and we need to change our drugs and begin taking better care of the patient, or more observant care of the patient is probably better to say it.
It's also the first thing that'll alarm if you have a balloon rupture,
Mhm.
as long as you have it on.
Yeah. Make sure you've got printer on the paper. That's another one that gets people.
Mm-hmm.
And always, always, always document this. I personally always document that I gave a report to the RN, to whoever's taking care of the patient. And it's common courtesy, but also it's it's important in your documentation to say that you did report to the person taking over what happened in the prior procedure and during the transport. And this is something a lot of people do. We actually started this, and I think it's a really neat thing. After your machine is discontinued, it's nice to have a little checklist on it, and basically you say that you put little checks. We did this, we did this, we did this, and in particular the helium tank is green, and that the console's plugged in because your batteries will die. Those are the two big ones. And that you put your initials and the date. What's today? Today's 8/17/23. And you put it on the machine so it's there for everybody to see, so they know that this machine is ready to go for the next patient. And the last thing I really want to talk about here that's not on our talk is the word augmentation. Augmentation is used to mean two different things. It's the same word, and they're totally different. Augmentation is used to describe the waveform bump that happens whenever the balloon inflates and you see the increase in systolic pressure. And it's also used to describe the amount of air that's going into the balloon. And so when we use the word augmentation, sometimes people get confused. I'll say I can decrease the augmentation, and that'll help out because the pressure's too high. And people look at you and they say, why do you want to do that for? Because they're thinking that you're going to do something to the timing of the balloon where it's inflating at. And that's not what you mean. What you mean is you're actually going to decrease the amount of helium going inside of the balloon. And so it's just important to know that the word augmentation is going to be used for two totally different things, and it's both used in the balloon pump world of lingos. Once again, I want to thank you guys so much for having me.
Perfect.
Yeah, and don't forget to like and subscribe if you haven't already. It really does help us out.
Well, before you switch, go ahead and switch over. And there's another question that I think you should. What do you think about benefits of the balloon use for, and either one of you can answer this, for use in diastolic dysfunction? Any thoughts? I don't have a good answer. I don't know.
Or as diastolic heart failure?
Yes, diastolic dysfunction.
What is the result of that led to the diastolic dysfunction?
I don't. They didn't ask that. They asked
So-
what do you think about benefits of IABP use for diastolic dysfunction? I think that's more of a cardiology medical thing, not something.
Diastolic dysfunction is usually EF preserved because it fails in diastole but not in systole. So they usually have a preserved ejection fraction, not usually needing a balloon pump on them.
You wouldn't recommend it? No. Okay.
My question would be,
No.
would that be related to aortic regurgitation?
Probably chronic heart failure patients. No, maybe
It's
it
like
could be, but I don't know
hypertension
that that's what they're
causes,
referring to,
yeah.
because you have diastolic dysfunction without aortic insufficiency,
Yeah.
right?
It's usually gonna be like hypertension,
Right. Yes.
stenosis, those kind of things. The ventricle just gets thin and flabby, and thick, and doesn't accept a lot of preload in diastole, but it can contract all day. It's got a good ejection fraction still, where systolic heart failure takes all the preload but does not have a good ejection fraction.
Well, hopefully that answered your question.
Yeah.
That's I think you had the best answer on that one.
Yeah.
I can't help you with it, and I think we have to defer to
the clinical
Vicki.
nursing
She's
perspective is far superior to us.
I
in
think
this
so.
one. Yeah, we're not.
very good. Okay.
Thank you.
Next up.
Okay. All right, so I have a couple radiographs here, X-ray right next to a CT, the carina being right here. The intercostal spaces I tend to not use because depending on the angle that they shot the chest X-ray, it can make it look considerably different if you're just going by intercostals. So I like to use the carina, which is right here. Of course, you got the aortic knob up here. You want to be approximately 1 centimeter below that. Another landmark that I like to use is the AP window right here. It's kind of like that little shadowing area where the pulmonary artery kind of crosses over the aorta. So that's one of them that I like to use. This whole white line actually is the carina. which a lot of studies have come out recently saying that's actually a better landmark than the intercostals, which is why we're pointing it out here. And then this line here being 1 centimeter below our left, our left radial artery comes off there.
Left subclavian.
Left subclavian, thank you.
I knew what you meant.
You knew what I meant. And this is also pointing to the left subclavian there. Okay, so anywhere in this area or this area, I tend to try to stay right at or above that AP window. Sometimes it's not always easy to see the carina, but if you can, being above that also is a very good landmark. And again, left subclavian. When you're palpating the radial arteries, you're not necessarily, if you're too far up, you're not necessarily going to lose your radial pulse there on the left, but if you feel them both at the same time, you'll feel a big difference between the two, which would be a sign that it's inserted too deeply. Okay. Did that explain it okay on
I
that
think
one?
so. Very good. Yeah.
Okay. Okay. So we've got 2 insertion techniques here. This one is femoral and this one is axillary. This X-ray here, a lot of the balloon pumps now only use 1 radiopaque marker. This one actually has 2. And so when you're looking at this one, it's very, very hard to discern if it is axillary insertion or femoral insertion, other than just this small sheath right here. If I hadn't had it highlighted up here, it wouldn't even be visible. So it's good to kind of like mark those things on your X-ray orders, even if it is to just verify placement of a balloon pump. Sometimes there's sternal wires, pacer wires, central lines, swans, chest tubes. There could be a whole lot going on in that chest X-ray, and the radiologist may not even be looking for a tiny little radiopaque marker. So it's good to mark this on here. It's not always as easy as it sounds. And I think there's another picture here. Actually, down here, can I zoom in on this? Okay. This bottom radiopaque marker is what's called a 2-tone radiopaque marker. You see how you've got like a darker area here and then a lighter area here. They don't all use this 2-tone marker, but it is a good way to tell which way it's going in. I guess that'd be the second way to verify on this one. It usually means the most distal tip of the catheter, meaning it would have gone in like this. Here's the other picture. There we go. Now, let me get my marker to erase here. Clear pin markings. Okay. This one is a femoral insertion, and again you see the 2-tone marker up here with the darker part and the lighter part, meaning it is inserted this way. This is a cool picture, however, because it actually caught the balloon inflated, which you don't always see that. It's kind of cool. So one of the ways you can kind of tell, but again, they don't always have that 2-tone marker, and they don't always have 2 radiopaque markers. Most of them nowadays just have 1 single-tone marker at the tip, so help your radiologist out and note what you're actually trying to get them to verify. Okay. Okay, this is the Wiggers diagram. I'm sure a lot of you have already seen this. We'll just go through it briefly here. We are comparing pressures to volume. So this top half here is going to be talking about the pressures, bottom half the volume, and then this is time through the cardiac cycle. So down here, these are just your sounds. So your lub-dub, third heart sounds are not always heard, but it can be younger people. You can kind of hear the sloshing as the ventricle fills there, but not always. This line here, of course, is your EKG, where it lines up with the pressures. So we'll start with the atrial. Well, actually, let's start with the ventricular pressures right here, the blue line. Okay, so we're gonna start here right at the isovolumetric contraction. As Joe mentioned earlier, this is where The ventricles start contracting, but the aortic valve and the mitral valve are still closed during this time, so you see the volume does not change just for that briefest of time. The aortic valve does not open until it exceeds the pressure in the aorta, which is right here. You see the pressure is higher there, pushing the aortic valve open and injecting the blood into the vasculature. Okay, right in here is where the ventricles are relaxing, the pressure is starting to dip, and now the aortic pressure is exceeding the pressure in the ventricle, and it closes the aortic valve. That extra little hump there is really just blood kind of filling those cusps of the aortic valve, causing an extra little hump as the valve closes. And of course, that's your dicrotic notch. Then this period here being the isovolumetric relaxation. And again, you can see down here the volume does not change because the aortic valve is closed and the mitral valve is not open yet. So volume does not change, but the pressure is dropping. Once it gets low enough so that the atrial pressure is now higher, then of course your mitral valve opens and you start getting filling. This is passive filling into the ventricles coming right through the mitral valve. This hump here is the atrial contraction, happens right after your P wave, and that adds an extra 10 to 15 mils to the volume going into your ventricle. This, by the way, is a left side Wigger's diagram. The right side one would look mostly the same, but with much lower pressures. Okay. We're looking at 120 here. It tells you this is a left side Wigger's diagram. Then, of course, you go through the cardiac cycle again. So down here, you can see where the volume comes out of the ventricle. Valve closes, the mitral valve opens, passive filling here, meets up with the volume in the ventricle, and so forth. This is kind of how it all lines up. So this is the area here that we are targeting. Okay, I think the next slide has the coronary perfusion. Okay. So this is the flow through the coronaries. This is your systolic cycle. So the pressure in the ventricles during systole is such that it does not get as good of perfusion. Again, left side is what we're talking about here. This is about...
Do my section, I have to take a call.
Okay. So during the systolic part of the cardiac cycle, we're looking at about 25% perfusion to the coronaries. When you get into diastole, the pressure is so much lower that now blood is able to get through there, and that is 75% of the perfusion to your heart itself. So on the right side of the heart, it's more 50-50 because it does not have the same amount of pressure as the left side does. So if you are having, well, actually, let me just also mention that blood flow through the coronaries, the oxygen extraction rate for them, because they're so metabolically active, is about 70%. Very, very high extraction ratio. The rest of the body, we use about 25% of our oxygen before it gets back to the heart. That's why our SpO2 is usually around 75. This is not true with the coronaries. The coronaries use about 70% of the oxygen that goes through. So if they need to increase oxygen or meet an increased demand, they really can't do it so much by increasing extraction. They have to increase blood flow. And the coronaries take about 5% of our total cardiac output. So if you have a situation where you're trying to improve blood flow, through the coronaries, the area that you're going to target is definitely going to be diastole, because the systolic phase has too high of pressures to increase flow. Where diastole, we have room with our augmentation with the balloon pump to increase flow to supply more oxygen to the cardiac muscle.
And that's a good time to ask the question that we were asked earlier today about heart rate, a high heart rate, and how a high heart rate affects the filling of the coronaries. Can you comment on that?
Actually, I have that coming up on one
great.
of my next slides when we start talking about the tension time index. That's a very good point. Your systolic phase is not going to change very much. Your QRS is going to be your QRS, but your diastolic phase is the part that, if your heart rate's going too fast, you're limiting your coronary perfusion just because you're not giving enough time for this 75% here. Okay. All right, counter pulsation. Counter pulsation just means opposite of what you'd expect, basically. So I kind of think of the balloon pump as two machines, my inflation machine and my deflation machine. So diastolic augmentation is going to be my inflation machine. It is going to increase my diastolic pressure, where without it, your diastolic pressure decreases. So we're going opposite of what you would expect, right? It increases coronary perfusion by pushing blood back. Remember, your coronaries come off prior to the aortic valve, so you get the best perfusion when the pressure is low during diastole and the valve is closed. You do get an increased map because you get that giant jump in your diastolic pressure. Okay, now your deflation machine, this one is when the balloon deflates and it causes a sudden drop in aortic pressure, kind of reducing the afterload. This is how you will increase your cardiac output, because it kind of gives that sudden drop in aortic pressure kind of makes it easier for the ventricle to dump the blood out. You'll get a higher stroke volume because there's not as much resistance for the heart to empty against. An increase of about 0.5 to 1 liter per minute, or up to 30% increase in ejection fraction with the deflation machine. Now, since that aortic pressure is a sudden drop, you end up with a lower systolic blood pressure. So lower systolic pressure, higher diastolic pressure, but you still end up with an increased MAP. Okay? Wall stress is a big deal because wall stress causes increased oxygen demand. And if you have somebody with some blockages, you're trying to get better oxygen demand versus supply ratio, you'd want to reduce that wall stress, which the balloon pump can do up to 20%. Resistance to the left ventricular ejection, again with that sudden drop in aortic pressure when the balloon deflates rapidly, gives an increase in afterload. Okay. Decreased in wedge pressure or in diastolic volume. Again, the ventricle is able to eject more of its volume with that reduced afterload. Okay, and we're going to talk about this here in just a moment. Okay, here's just another graph kind of showing where the balloon pump lines up. Of course, here is our QRS. And we deflate. On our QRS is going to be our ventricular depolarization, or our contraction. Okay, and then the end of the T wave is the repolarization, or start of diastole, which is where we want our balloon to inflate. This is our augmentation hump here. Okay. So DPTI and TTI ratio, this is really just like a quantitative way to look at supply and demand inside the heart. So DPTI is diastolic pressure time index. And this is how you would measure the amount of blood we're able to get to the coronary muscle during diastole. So this is our kind of a direct measurement of coronary blood supply. And it's calculated using the coronary perfusion pressure and the diastolic time. Okay, and this is what Thomas was talking about just a little while ago. The time spent in diastole is a huge factor here. Coronary perfusion pressure, I just kind of included that down here. That's just going to be your diastolic pressure minus your wedge or your end diastolic pressure. Same thing. Okay, now to measure your oxygen demand is going to be the tension time index, this one here. And this is telling us basically the work the heart's having to do, give us a measurement of our oxygen demand. And it's measured using the systolic pressure and the time spent in systole. The time spent in systole is pretty much fixed at 200 milliseconds. That does not change very much. So you would use the 0.2 to calculate that one. The ratio, then you would put your DPTI over your TTI, and that ratio gives us our endocardial viability ratio. Okay, so this is going to be basically our oxygen supply and demand balance. If your EVR is 1 or above, you're doing good. Less than 0.7 is typical of ischemia. Okay, so you will see these numbers possibly on cath lab reports where they reference DPTI or TTI, but you will see this in every balloon pump article that you read, any research on balloon pump. This is always going to show up. So this is kind of giving you what that's talking about, because the balloon pump directly affects both of these things. We are going to increase our DPTI because we're increasing our diastolic blood pressure. Okay, so that is increasing blood supply. We are going to reduce our TTI because we're reducing our systolic pressure, which is our oxygen demand. So both our machines, our deflation machine and our inflation machine, that's what they're doing. This is just an example. We have patient's blood pressure, heart rate, wedge here. So if we are going to kind of look at this DPTI, again, diastolic pressure minus wedge or end diastolic pressure. So our 95 minus our wedge is how we get our 80. 60, the 0.2 seconds is going to be that systolic time. That really doesn't change very much. It's pretty much a consistent, is how we're going to calculate that out with our heart rate. Tension time index, systolic pressure minus systolic time. Again, the 0.2. You're going to put 24 over 36, and this patient is having ischemia because we're less than the 0.7. Our problems here is our blood pressure is too high, making our tension time index too high, and our heart rate is too high. So our time spent in diastole is too little, throwing off our ratio.
That makes so much sense.
All my scribbles?
No, all of that you just said, I think summed it all up.
I love
really
the
summed it up.
DPTI, and the TTI is a really good
Understanding that.
Does this information come from a thermal dilution swan or?
If you are taking wedge pressures, you would use a swan. If you have that luxury, but not all patients have that swan in place, unfortunately. But yes, if you're wanting to calculate your coronary perfusion pressure, you would need a wedge pressure. If you are using, for the right side of the heart, this of course is for the left side of the heart, but for the right side of the heart, it would be your CVP that you're using. Wedge pressure basically being the CVP of the left. So when we're talking about coronary perfusion pressure, we're usually talking about the left side because the right side has 50-50 perfusion in systole and diastole, so it doesn't really matter as much as the left.
Yes.
So all the slides I know I mentioned already, but most of these are referencing left side. Okay, here is an illustration. Again, here's our augmentation, DPTI. You can see it right on it there. Okay. All right, so that brings us to our waveform. So to kind of sum up the last part of the slide, we have our balloon, which is the very first thing I always look for when I'm looking at my waveform. This is our augmentation during diastole. So this is going to be our DPTI. And down here is where our balloon deflated suddenly, giving us this drop, 15 to 20% drop. You're starting from a lower here, you're going to end up lower here. This is going to be lowering your TTI, your tension time index. Okay, so kind of how that lines up to your balloon pump, what we just talked. Okay, so other landmarks, dicrotic notch, you want it to be lined up with your inflation point. You don't want to see your dicrotic notch, but you want it to inflate right about the same time where your dicrotic notch would be. And then I like to call them door to door. Joe explained how opening the door, it's like the Stooges falling through. That's why I call them door to door, but it's your end diastolic to your end diastolic. The balloon does the assisting, so that is your assisted beat and your unassisted beat. You always want your end diastolic to be less after your balloon has done the assistance. You want it to make it easier for the heart to open that door. Okay? So those are your landmarks.
But one doesn't help. So go back. So
Come back.
having a lower assisted aortic end diastolic pressure that you're showing there, is kind of highlighted so people know what I'm looking at.
Right here.
Having that in isolation is meaningless. You have to have the assisted systolic in comparison to the unassisted systolic
Correct.
combined. Because if you only look at one thing, you can't say that it has actually benefited the patient. And the reason for that is if you deflate it too early, you will have a lower assisted aortic and diastolic pressure,
Yes.
but you will not have affected the afterload at all because you allowed too much time for equilibrium to take place, and the heart is then contracting against the same afterload as if you didn't have a balloon at all. So never look at one thing in isolation. You have to look at the big picture.
Correct.
Go on, I'm sorry.
And this also
I wanted to
cannot be
highlight
assessed
that.
on one-to-one.
Correct, but we're going to get into that.
We're going to get into that. It's a pet peeve of mine. Lots of times I see the one-to-one strips all over the
All the
chart,
time.
and it makes me crazy. All right, so variables that can affect your augmentation. So balloon position is going to be your main one. The closer you are to the aortic valve, the greater your augmentation will be. Likewise, if you're too far from the aortic valve, your augmentation will be less. Balloon volume. If you have a balloon volume that's closer to your stroke volume, you're going to have the best augmentation. Likewise, like he was talking about, if you decrease the augmentation of your balloon, so if you have a 40 cc balloon and you decrease to half augmentation, you'd be just 20 cc balloon, and you're going to have a lower augmentation hump. Okay.
Yeah.
Balloon diameter. So that's an exclusive, how occlusive it is of the aorta. 100% would be great augmentation, but we don't want it to be 100% because that's could cause damage to the vessel wall. Timing errors, of course. Stroke volume, this kind of goes back to using the right machine for the right patient. If your patient has a stroke volume less than 20, you're probably not using the right machine if you have a balloon pump in.
Impella.
The Impella would be better. So if you have a 40 cc balloon trying to augment 20 cc's of cardiac output, it's not going to do much good. Of course, vasodilation and constriction, either from compensation mechanisms or medications. Okay, here's another example of the waveform. We talked about that just a minute ago. This one is just more of a realistic strip here. Balloon, dicrotic notch to dicrotic notch, door to door. Okay, I think Joe is going to go over some
Nope,
more of
I'm
the
going to let
timing.
you keep going.
You're going to.
You're too good at it. You're better than me.
Okay, so this is a 1-to-1 strip. So here's your balloon. This is assisted. Balloon assisted. Balloon assisted. You cannot compare it to anything. You cannot assess your timing. Okay? Don't put this on the chart. All right, so here we have our first timing error. And I like to think of them as the same thing, my two machines, my inflation errors and my deflation errors. First, find your balloon. Okay, looks good. Now I'm looking at my assisted to my unassisted, and I am going to find my dicrotic notch, which means right here. We have all this time that is, it's too early, like it went off that much earlier in the cardiac cycle. This is an early inflation. This should have come down and then inflated up here.
And if it does that, what happens?
So if you inflate that early in the cardiac cycle, you're pretty much forcing the aortic valve closed prematurely. The ventricle is going to fill with blood that it wasn't able to eject all the way, and you're increasing the wall tension.
Because that's
tension
really
time
going to be in
index.
what would be called the reduced ejection phase.
For sure.
Right, or just the earliest portion of
Correct.
isovolumetric relaxation.
Correct. So increasing the workload of the heart, opposite of what we're wanting to do. So our inflation machine is not good. Deflation, on the other hand, we have our door to door, so our deflation is doing okay as far as that part goes, but we're causing damage with our inflation. Okay?
Now-
It can cause aortic regurgitation.
The next one, yes, it can do that too. The next one that you do, yeah, it probably will. The next one that you do, if anybody can answer the question before we say what it is, they will win a prize. But you have to be quick. So you have to be paying attention. You have to be on live. And so you got to be quick. If you can answered the timing error before she says what it is, you win a prize.
How much time do I have?
Huh?
How much time do I have before
Go
I
ahead,
say it?
next. Next. No prizes for you.
Okay.
You're what is it called when you're excluded? You're not excluded. You're
Exempt.
exempt. Yeah.
Exempt from the rewards?
Yes, you can't. Yes, you can't be a part of the game.
I'm still going to get another coffee, though.
You can. Next.
Do I count it down or?
No, just go to
Okay.
the next one. Oh, you're on the next one.
Yeah.
I am on the
Oh,
next
I'll
one.
do it before you. Yeah, just go ahead through the explanation.
Has anybody got the answer?
See if
Okay.
anybody gets it. I'm watching.
So first thing I do, I find my balloon right here. Second thing I do, I check my inflation, so dicrotic notch
Dicrotic
to
notch.
dicrotic notch. Okay, but we don't want to see the dicrotic notch, and I can definitely see my dicrotic notch. This is a late inflation.
Late inflation. Okay, nobody
Okay.
got that one, but that's late
So-
inflation. Now you know what that looks like.
What's happening here is our aortic valve closed. You entered diastole. All the blood runs off down into circulation called aortic runoff. And then our balloon inflates. So there's just not as much volume left in the aorta to augment back to the heart as well. Most of the blood has already passed the balloon.
And you're losing some perfusion time.
Exactly.
Augmented perfusion time. So you're
Exactly.
missing out on an opportunity to get even more O2 to the myocardium.
So
You're
sub-
losing that diastolic pressure. You're losing
Exactly.
the time part of that whole process.
Correct. So suboptimal coronary perfusion with your balloon inflation. Again, our door-to-door on our deflation is good, so we're still reducing our afterload, but we're only getting half of a machine when we should be getting two machines here.
But of all of the timing errors,
This is the best one.
this is the best
one to
one.
have,
Yes.
This is the best one to have. Okay, ready? All right, here is the one that Joe wanted to really point out. He talked about it earlier.
See if anybody gets this one.
Okay, hopefully somebody does. Here's our balloon. Okay, so
Super cool prize.
dicrotic notch to dicrotic notch. That looks appropriate.
Right.
So our inflation machine is properly timed. Okay, now here is our tricky part, our door-to-door, our door-to-door. So here is the assist. Our balloon deflated. We got that 15% decreased afterload, but then it went away. It went back to what the pressure was before the balloon deflated, and then our next cardiac systole started. So it's not getting any assistance here. It's ejecting against the same pressure as before. We just wasted our assist.
So basically what happened, and nobody got that one either, what happened was you're on the one side of the door, you want to push through the door, somebody opened it before you were actually pushing and then reclosed it. You got zero benefit. You got no help getting through the door.
Okay, so the tricky part with this time
Early deflation. Harsh Patel. You win a prize. Harsh, send me a email to contact@perfusioneducation.com with your address, and you will receive something in the mail.
Okay, so the tricky
Good
part.
job.
Yeah, good job. The tricky part with this timing error, not only are you getting suboptimal afterload reduction, but you can actually, because you are deflating and creating that sudden drop in aortic pressure before the next systolic cycle starts, you're risking retrograde coronary blood flow and retrograde
that's a very good
from
point.
Blood
your
out.
carotids.
Very good
You can
point.
actually cause ischemia with this timing error.
That's interesting. Yeah, I never thought about that. That's true.
That's the danger with this one. Okay. Here is our next one. We're going to find our balloon. Okay. Then our dicrotic notch. To our dicrotic notch, our inflation balloon, our inflation machine, and it looks beautiful, well timed. Okay. Now we'll go to our door to door. And here is our problem. We should never have a harder door to open after our balloon is inflated than before. So basically, instead of our balloon doing assistance, our balloon is still in the way.
Yep.
It's still inflated, causing it harder. So our door to door is harder after the balloon did the assistance. This one, of course, is causing increased afterload. It's the same thing if we were making our patient super hypertensive with a blockage in the coronary.
So in this particular case, you always want your assisted systolic to be lower than your unassisted systolic,
Always.
unless, in this case it is, right? One could say, oh, it's less, that makes sense. But it's lower, not because of decreased afterload, it's lower because it has failed.
It has
We're
failed.
making it fail. We're causing the heart to be unable to eject, and that's why the pressure is lower. So again, remember what I said earlier. You can't just look at one number. You have to think about the whole picture.
Just remember that balloon, 40 cc balloon, suddenly deflates. Where did that assistance go? There's just no reason that it should be higher after the balloon unless the balloon is still in the way. Okay. Hey, it's me again. You want to do mine?
No, you go ahead. You're better at this than me.
Yeah.
Okay. So now these next strips are going to have multiple timing errors.
Okay, let's see if anybody can get them. Come on.
Yeah?
Harsh, and you can win two things. If you know the answer, if you can tell us what this is, and you can get it in before Vicky reveals it, you're good to go.
Okay. So I'm going to first always find your balloon first so you know which one is your assisted versus your unassisted. Then I'm going to find my dicrotic notch, to my dicrotic notch, and I can see my dicrotic notch. Anytime you see this little flat W or M shape in the middle, that's always a sign of late inflation. So we're getting suboptimal coronary perfusion. Okay, then we have the other on our deflation machine, our door to door. So here is our assist, and our heart is actually ejecting here. So early deflation, late inflation. Aside from the risk of having retrograde coronary and carotid blood flow, this patient is getting absolutely no benefit whatsoever. We're not getting reduced afterload, and we're not getting increased augmentation to our coronaries. Why bother having the balloon pump at all?
Correct. So the answer is late inflation. Early deflation.
Okay.
And so we
Did
did have
anybody
somebody guess premature inflation, so no, but I put the answer on there. Late inflation, early deflation. So you're reducing your diastolic perfusion time, and you're also not allowing the balloon to deflate too early so that you don't have a reduction in your afterload. So it's going back to my going through the door. With late deflation, you're trying to open the door, but you've already gotten it open before the person actually goes to help.
Yeah.
So that's the reason for the assisted systolic not being lower than the unassisted. You basically have no afterload reduction. So late inflation, early deflation. Go ahead.
Okay. This is by far the worst combination out of all of them. This patient should have gone to a different hospital.
Should have.
Okay, so we will find our balloon, and then dicrotic notch to dicrotic notch, and we are well before we should be. So
Don't
early
give the answers.
inflation-
Don't give all the answers.
I thought-
You're
okay.
just giving all the answers.
You didn't give me a time.
So somebody quick, write
Go
that
ahead.
down. Turn it
Do you want me
in.
to keep going?
No, yeah, keep going.
Okay.
Now.
Yeah.
So our balloon inflated this much too
Too
early
early.
in the cardiac cycle. So we are forcing our aortic valve closed. We're increasing our wall tension because the ventricle can't empty all the way. No bueno. Okay, so then our door to door, we are higher. So our balloon is still in the way because it is a late deflate, making our afterload higher. So this patient's probably going to start having some angina. You can probably start getting some tachycardia. You're going to see signs of decompensation, and this would be a waveform that you would immediately have to retime. Again, knowing these waveforms is half of the battle, because if you don't know them, you don't even know there's a problem. I don't know if you're at a place where you're not allowed to retime, you'd put it on 1 to 3 so that you're only doing the damage every third beat until somebody there can get timing right.
And lower the augmentation way
Lower
down.
the augmentation down, correct.
The balloon volume.
The amount of
You
volume,
can't
right.
turn it off, but you can definitely reduce the amount.
You could if you're anticoagulated.
At least for a little while.
Anticoagulated, you can do anything.
I prefer to retime it very quickly.
Okay.
But yes.
Okay, we're really running out of
sorry.
time.
Okay.
That's okay.
Anticoagulation, we were just talking about
Anticoagulation.
that. Heparin is the most common, reduces the risk of thrombus, thromboembolism, and limb ischemia. PTT ranges per physician anywhere between 50 to 70, but again, sometimes nowadays we don't even anticoagulate as long as we're on 1 to 1. If we're on 1 to 2, I always push for something. Argatroban and bilvalirudin are used for patients with HIT. Here's that anticoagulation may not always be needed, but if you're 1 to 2, 1 to 3, it's best to be anticoagulated. These are some studies that did complications with coagulation versus no anticoagulation, 1-to-1 balloon pump ratios, and we did see some mixed results here, higher risk of bleeding, but no statistical differences in limb ischemia. Same on this one down here. This one had less limb ischemia, and they recommended it. So just kind of an overview of what the current studies are. Adverse effects of balloon pump, injury to artery. Also, one of the things Thomas was talking about with the gauze under there, sometimes if that isn't inserted right and you don't have the gauze under there, it can cause some injury to your femoral artery. Infection, anything in the body can cause infection. Ruptured balloon. This is an emergency. You start seeing that blood coming out of the tubing, but hopefully you had your augmentation alarm set and you would know before you see the blood. At that point, it's different per facility, but typically we go by a 30-minute window to get that thing out, and after that it has to go to the CV surgeon because of this reason right here. If blood's coming out your tubing, it's filling up your balloon as well, making a big clot, and you can't pull that out of the artery. Balloon entrapment, that's kind of the same issue. You have to surgically remove it. Incorrect placement, limb ischemia, stroke from clots, bleeding, aortic dissection, all complications. And then Joe,
Next slide. You just put the slide.
I'll let you do that.
Okay.
That was your
Okay,
slide.
so this is my fun slide. The this up here, and it's more for cardiopulmonary bypass, and I want to talk Thomas to get in on this as
Sure.
well. But the use of the balloon on CPB for pulsatility. This study is very good, and really there is no compelling by any stretch evidence to support pulsatility on cardiopulmonary bypass. And I don't want to get into the weeds with this, but leave it to say your aortic outflow is about 2.5 centimeters, and it only has a very short distance from the ventricle to the aorta, and the pump is pumping through about 10 feet of line, an oxygenator in between, and going through a 7 millimeter cannula and trying to generate a pulse. So I think it's a really bad idea, but that's not the point of this lecture. If you have a balloon pump in and you turn it on, this is the waveform you will generally see. And the balloon is inflating, staying inflated, actively deflating, because you're flowing continuous and the balloon is just basically interrupting that flow and causing the pressure to spike like that. So that's what you generally will see. It is controversial. It may create some surplus hemodynamic energy, maybe. The only studies on pulsatile flow did show, the only thing that ever was shown was a very slight improvement in AKI postoperatively if you use the balloon pump to generate the pulse versus anything else. But most people really don't have balloon pumps when you're doing cardiac surgery. So if you have it, it's going to not do any harm to put it on pulse, internal rate of 80. You have to remove the EKG cable or it will continue to alarm. And I would absolutely not recommend doing it if you are femorally cannulated, because now you're pumping retrograde, balloon inflating, you're interrupting flow to the body, to the brain and the upper part of the body. So I think it is imprudent. I wouldn't recommend it. And I don't really have any data, but common sense tells me you shouldn't do it. This is what it looks like on an internal rate of 80 as the balloon pump generated pulsation during cardiopulmonary bypass. What are your thoughts?
The first thought is femoral cannulation versus central cannulation.
Yes, this is central cannulation.
Right. So this is what central cannulation looks like. So yeah, femoral cannulation, it doesn't make sense. So in that case, I would probably turn the balloon off, make sure you're anticoagulated. Since you're on bypass, you're anticoagulated. Turn the balloon off, just leave it off. You know, you're centrally cannulated. If the surgeon looks at me and says, turn it on, I'll turn it on. But for the most part, I always kind of wonder about this counterpulsation flow going backwards and causing the heart to, or blood to come out the coronary arteries while they're trying to sew on the coronary artery.
But that's an off, but if you're clamped, it can't do that. Mm. If your aorta is cross-clamped and you're on cardioplegia,
when you're off,
that's not going to happen. Right? Can't go down the coronaries.
Right.
Right. Now, if you're doing an off-pump case, it can make it more challenging, but sometimes those off-pump cases are unstable. You don't want to go on pump, so it may be beneficial. I don't know. Mm-hmm. But do you use it for pulsation when you have it, just for your standard cases? Generally not in the med center?
No.
Because most of our guys do. The data, just so you know, data-wise, there's no harm that I have found. There's nothing that says you shouldn't do this. So I consider it to be personal preference. Can use it. Probably doesn't really do any good. There's no data that it does any good, no data that does any harm. So I think you can do it, maybe not do it, depending on what you want to do.
Would you do it on a case-by-case?
No, I'm either going to do it or
Not do it.
I don't really have any criteria for it.
Yeah, question.
Question, how long recommendation use of IABP post-cabbage? I mean, I guess as long as you need.
Yeah.
We do have a whole weaning section, but we've long run out of time. We're like 18 minutes behind. So what we're going to do is we're going to have another, only this time we're going to change it up a little bit and maybe do a part 2 where management of the patient and weaning will be a part of that. So with that, we're going to have to bid everyone adieu. Great presentation. Sorry we ran over. Thank you for your patience, and we will see you next time. Thank you all very much.